Thank you for joining us for Talking Sleep, a podcast of the American Academy of Sleep Medicine. I'm your host, Dr. Seema Khosla, Medical Director of the North Dakota Center for Sleep in Fargo. As we approach the third anniversary of the Philips Respironics recall, we have largely shifted from helping our patients register their devices and trying to navigate the CPAP shortage to more nuanced details that may have gone unnoticed. While CPAP devices are fairly similar across different manufacturers, there are more significant differences in the advanced modalities of ventilatory support. Dr. Lisa Wolfe is well known for her granular knowledge of mechanical ventilation, including non-invasive ventilation, and is here to shed light on some aspects of NIV that may become pertinent as patients transition off of Philips recalled devices. She is an associate professor of medicine and neurology at Northwestern University and is the medical director of respiratory care at the Shirley Ryan Ability Lab, both in Chicago. The focus of her work is studying devices for ventilatory support used in home-based settings. Thanks for joining us today.
Thanks for inviting me.
So you have a large population of patients with neuromuscular disorders. So are your concerns primarily related to this population?
So we do have a lot of concerns for our patients that have neuromuscular diseases. The largest concern focuses on patients who were using Trilogy home-style ventilators because these devices provided modes of ventilation that may not have been available on other classic sleep devices. For instance, mouthpiece ventilation or volume-assured pressure support, especially volume-assured pressure support with auto EPAP. And so we are looking at transitioning patients to other manufacturers, but it does mean learning new language, new modes, and new technologies.
So let's start with the sleep lab. So we know that the in-lab titration devices for Philips were recalled and they have not been remediated. So has that impacted you at all?
So there has been a huge impact that way because realistically, the only options that we have in the sleep community is to use the OmniLab, the Respironics device, or to use the ResMed device. And the ResMed devices have been on back order. They've been difficult for labs to obtain. And there is a direct link between the software that we're using in the lab and the device that the patient should be set up on. So when we look at advanced modes of non-invasive ventilation, if I'm trying to titrate with an OmniLab, but then put the patient on a ResMed device in the community, really important settings will get unaddressed. Things like inspiratory time, trigger sensitivity, rise, all of those kind of what we call minor settings, but are really fundamental to actual patient compliance and effective ventilation. And we are just going to have a prolonged transition time because device shortage in terms of sleep recording has continued, even though our straightforward CPAP device shortage issues are much less prominent.
So you're talking about AutoTrack, right?
So AutoTrack is a big component to this.
Okay.
So AutoTrack was a software program that was available in the Respironics devices. And AutoTrack was a very early adoption of what you and I would call AI technology, where you could look at a group of patients and evaluate how they breathe, when they start the breath, when they end the breath, what the shape of the breath should be. And that software then would make those decisions. The problem is ultimately that software did have the flaw that it didn't look at every patient type. It wasn't developed looking at women or children, those with neuromuscular disease or end-stage COPD. And so in the end, it probably is better for patients that we have doctors at the bedside tuning these minor settings. But certainly our technologists are not used to doing it. And we even have a lack of support from home DME companies that aren't as comfortable with setting each comfort setting individually because they're used to having the software do it for them.
Oh, so does AutoTrack live then on the home device and the in-lab device?
It lives both places. And
Mm.
if you take that software out, it is not going to be equivalent device to device. So if you do a titration in the lab on an OmniLab with AutoTrack activated, and then send someone home with a ResMed device that's not using AutoTrack, you're going to have a really good understanding both of your patient's physiology, what they need, and then also how to make that work on the home device. That's a big education and knowledge gap that exists completely down the chain from top to bottom, from sleep tech to DME company to respiratory therapist to even sleep professional.
Mm-hmm. No, I believe it. After we chatted, I actually went and watched your choosing sleep video, and it was excellent. And it made me feel like I was a fellow again. So I was like, oh, yeah, I haven't had to do this in a really long time. And so that was kind of where I was left, is this then something that we will have to script, or is this something that the
Yeah.
DME will do?
So I feel like the best way to assure that you're going to get the best thing for your patient is for you to make the decision at the bedside with your patient's involvement and feedback. Because trying to do this in an algorithmic way is not going to be as successful. I actually do find that choosing sleep video has held the test of time. And I do recommend for anyone who's making that leap from using AutoTrack to trying to independently set those settings, to actually go back to the choosing sleep video as a good refresher course for what's going to need to be done.
And so this is more, right? You mentioned this more than just IPAP and EPAP. So what specifically, what other settings do we need to consider?
So it really depends on patient physiology. So for instance, in our neuromuscular patients, trigger sensitivity is going to be most important. The device has to be highly sensitive so that the patient can easily trigger the breath. In patients who have, say, obesity hypoventilation with a lot of atelectasis, prolonging inspiratory time to really get those bases open is going to be really fundamental. On the flip side, in our patients that have COPD, for whom we need to get the breath in quickly so that they can have adequate time to exhale and deflate, and also feel like their breathing is really being adequately supported, we need to make sure the rise time is very fast. And so learning the specifics that are going to relate both the subsetting and patient physiology together, that's the ticket.
And so when you say do this at the bedside, you mean in the lab or do you mean in clinic?
Ultimately, when we look at the generation of evolving sleep labs, we are now living in an era when home sleep testing and auto CPAP means that we aren't seeing as much straightforward obstructive sleep apnea in our sleep labs. Our sleep labs are now places where very complex patients live. These patients that have underlying alternative diagnoses, such as neuromuscular disease, obesity, COPD, but also things like underlying parenchymal lung disease that may require oxygen, or more complicated issues of the upper airway. And so I feel like the initial home base needs to be an expanded sleep lab where technologists can look at these minor settings and adjust them to patient comfort.
So do you think then these more complex patients will wind up at tertiary referral centers or academic facilities rather than sort of out in community sleep labs?
I think that it depends on where you live and what's going on. I live in the city of Chicago in a hospital system that has, 10 hospitals in the system. And so it's very easy for anyone to say, wow, this is a patient with profound neuromuscular disease. I'm going to send them downtown and have the downtown lab do it. But in our ALS program, we cover patients who are from a several state area. It's very common for me to have a referral from Iowa, Michigan, or Wisconsin, even parts of Indiana. And so what I think we're going to need is an expansion of sleep labs that are community labs, but in relative small or rural communities that can also step up to do this. And so I think that you're going to see a need that's universal. And I do think that we can meet the need.
Well, and it's funny that you say that. I practice in Fargo, North Dakota, which is sort of one of the bigger cities in North Dakota. And we recently had a referral for a patient who had a trach. And
Yeah.
I wound up, reaching out to the tech and reaching out to the manager, and we sort of talked through. And we actually wound up referring to a larger facility because our techs were not comfortable with that patient. And so I feel like there's a certain amount of, like, you don't want to put your techs in a bad situation, right? You
Yeah.
want to do what's best for your patients and your techs. But if I'm hearing you correctly, it also means that we probably do need to be better prepared for these more complex patients.
So, what I will tell you we have done as a bridge to try and help get the comfort level there is that we now have to-go equipment, recording equipment that we can bring into the hospital. And when we have patients that have more complex medical needs, like an LVAD, the need for dialysis, recent tracheostomy or airway surgery, or my favorite, which is when I get the call from the cardiologist that says, our patient gets big, long systoles during sleep. Can I send them for a sleep study?
Oh, no.
Yeah, my techs don't like that. So what we've started to do is to do inpatient recordings and do them on the units that are most comfortable taking care of these patients, because the nursing staff and the respiratory therapy staff has already been trained. What's interesting for us is that we also now do high flow as a mode of ventilation in our sleep lab, but that's how we introduced high flow. Our first, I don't know, probably 10, 12 high flow studies were done as an inpatient with to-go equipment and the support of a respiratory therapist. And as our technologists got more and more comfortable with the technology, we can now run those studies in the sleep lab. But there needs to be some bridging and support for the RT, recognizing that this represents a fundamental change in how we practice healthcare.
So when you talk about to-go testing, what is that?
We have a portable machine that we can bring to any of the units in our hospital. And we can do full polysomnography with a one-to-one tech, and we can record as many leads as we need to.
Oh, that's kind of amazing that you can support that.
Yeah, it's one of these things that's challenging because, when a patient is admitted to the hospital, the cost for that comes under a disease-related grouping.
Right.
And many hospitals will say, well, we're not going to support the sleep lab to provide this service. But what we've been fortunate with is to convince the hospital that in order to keep our technologists and to not have issues with employee turnover, that if we have this extra technology, we can provide better care, we can get patients out of the hospital early and reduce length of stay, as well as keeping our technologists happy. And in the end, we were able to make that case.
So do you have a full inpatient sleep consult service then?
We just make it a combination between our pulmonary consult service and our sleep training program. And between the two, we can provide full inpatient sleep consultation.
I think that's fantastic. So I'm thinking about some very specific patients. So let's say you have somebody with COPD who needs bilevel PAP. So how should I think about the trigger, the cycle settings? Like, what should I be aware of for that patient?
Yeah, so there's a lot there. It depends on how severe, but
Mm.
let's assume that their PCO2 is elevated over 52 and that their oxygen requirement is more than 2 liters. And if we're in that situation, what we know is the most important setting is to get the IPAP greater than 18, because in those patients, high pressure support is the thing that reduces hospital readmissions and actually reduces mortality.
Really?
Yeah. Yeah. The high intensity pressure support studies, the most important of which are the Conline study and the Murphy study, both showed this. What's interesting, though, is if you look at both Conline and Murphy, they were done in European patient populations that are super skinny. And so they didn't really titrate their EPAP very much. It's like 4. That
Oh,
was it.
wow, that is a high pressure support. Okay.
However, in the US, our patients tend to have obesity together with a lot of tobacco exposure and underlying COPD. And so the titrations are a little bit more complex, and how to treat them is a little bit more challenging. But what we do know is that in a COPD patient, typically we're going to have the trigger and cycle at a medium realm. But if we see that there's a lot of double triggering or over triggering, then we can change the trigger sensitivity to low. So it's sort of the opposite of what you would see in neuromuscular disease. And this also helps us to make sure that the breath is being delivered quickly so that there can be a sufficient amount of time for exhale.
I do remember when I was a resident, I think we had somebody with bad COPD on a ventilator. And I remember the attending coming in the morning and putting her respiratory rate down to 2 so that she could exhale.
Yeah.
And that stayed with me.
Yeah. Yeah, it's pretty incredible how much we need to remember that sometimes in the setting of COPD, making sure that our pressures are adequate rather than trying to extend the breath is going to be super important. And it is the complete flip opposite to what you would see in neuromuscular disease.
So let's talk about neuromuscular disease. So you talked about the trigger. What about pressure support? What about those other considerations?
So we do like to see an adequate inspiratory time in our patients with neuromuscular disease. We, on average, are going to be at 1.2 in terms of inspiratory time. We do have patients that vary from that. If there's additional scoliosis or a lot of bulbar dysfunction, you may need to reduce that to 0.8. On the flip side, in some of our patients, especially that have either spinal cord injury where it's difficult to feel the chest wall, or in patients that have just a physiology where they want a really long breath, we will go as high as 1.4 or 1.5.
Oh,
But what
wow.
you have to be super careful of is knowing that if once you sort of get past that 1.2 on your inspiratory time, the downside is aerophagia. And the aerophagia, sort of burping and belching, but more important, risk of aspiration can be a downside. So you don't want to just say that all it's about is extending the inspiratory time, but it's a big piece of what's going on.
So then what about, you kind of touched on obesity hypoventilation earlier. Are there other pearls that we need to know about this patient cohort?
Yeah, so for obesity hypoventilation, one of the big mistakes that we see a lot is that the technologists, given the way that the algorithms are and the current AASM guidelines, we kind of want to max out CPAP before going to bilevel. And that's the way we've done it forever. But the problem is in true obesity hypoventilation, you may get yourself what I call ceiling limited, where the CPAP is so high that by the time you get to bilevel, there's no room to have an adequate driving pressure. And so you want to make sure that when you flip over to bilevel, you drop your expiratory pressure significantly in order to allow yourself a driving pressure. And this is a time where prolonged inspiratory pressure can be helpful as well. Remembering that the area under the curve of a pressure time curve is going to be proportional to the volume. And so if we don't have enough room to drive the volume on pressure support, either because you've maxed out your settings or because the delta is too small, you can extend that TI time as another way of driving up that volume.
Oh, that's a good idea. So
If
you
that makes
mentioned,
sense.
yeah, no, it does. It does. So you said something earlier about translating. And so, of course, this makes me think about, well, what about our patients on ASV and how do we translate the Respironics script into a ResMed one?
Yeah, so they are very, very different devices. Remember that in the Respironics device, we had the option of adjusting the respiratory rate. You could put it in auto, but you had the option of doing it yourself. You lose that as you go to the ResMed. So if you have, say, a lab that's running OmniLab and the techs are independently adjusting the backup rate, that will go away if you dispense a ResMed device. And so just needing to be cognizant that if you're going to dispense a ResMed device, make sure that your backup rate is auto.
And everything else should translate pretty straight over, right?
Relatively well, because the other issue is that if you're using the backup rate individually assessed on an OmniLab, you'll also need to adjust your inspiratory time. But all of that goes away if you go to the auto backup rate. And I am not a person who in general likes auto backup rate, but for the situation of ASV, that's the best way to go.
I'm so glad to hear you say that because I'm not a big fan of, the backup rate either, but I kind of like the ASV one.
Yeah. Yeah, it's the right time, it's the right place.
Yeah. So let's take a short break, and when we come back, we'll talk more about some of the more nuanced considerations with the Philips Respironics recall as they relate to NIV. You're listening to Talking Sleep from the American Academy of Sleep Medicine.
Calling all sleep medicine physicians, researchers, and fellows who strive to be at the forefront of their field. The highly anticipated sleep meeting, hosted by the Associated Professional Sleep Societies, is back and better than ever. The sleep meeting is more than just a conference. It's a chance to enhance your skills, exchange groundbreaking ideas, and collaborate on innovative research projects. Plus, attendees earn valuable CME and MOC credits while expanding their professional knowledge. Visit sleepmeeting.org today to register and secure your spot at Sleep 2024. Register by April 21st for reduced pricing.
Welcome back to Talking Sleep. We're talking with Dr. Lisa Wolfe about things we need to think about as we transition our patients from a recalled device. So let's shift to our inpatients. I think this was the latest sort of update, to the recall, although honestly, I'm losing track. So they recalled the V30, V60, and Evo devices. So do those translate?
Yeah, so this is, I think, going to be the biggest challenge that we have moving forward. The challenges come for several reasons. One, there's no obvious alternative in the US. And so because we don't have good obvious alternatives for these devices, we're continuing to use them. And patients are not aware that we're continuing to use them. In many hospital systems, if they're still running an OmniLab, you may even tell your patient or have them consent at the beginning of their study. But that same hospital system in their ICU is wheeling in a V60, putting it on the patient, and not letting the patient aware that there's a recall. Listen, this is the reality, because in critically ill patients, if I have nothing else to offer, why tell them there's a recall? Because there may not be any other option. One of the reasons that we have such an issue is because of call systems and nurse monitoring systems, which are not available on typical home devices. Really, only critical care devices have that available. And so trying to increase the number of options for that has been a big challenge.
Oh, that's a really good consideration. So when we talk about recalled devices, is this only sort of ventilators and respiratory stuff, or does other stuff get recalled?
So that is a very good point. If we look at our intensive care units and our inpatient units in general, recall devices turn out to be everywhere, from med pumps to pharmaceutical machines to parts of beds or OT equipment. And so it turns out that there are levels of recall. Now, the Respironics recall has been a level 1 recall, so it's one that we're more serious about. But I think that it's worth it if you work in an inpatient setting to actually meet with the safety officer for the hospital and try to have an understanding of how the recalled devices that we're still using fit into the larger landscape of potentially other recalled devices within your ICU, and how you're going to handle it, that you may be approaching this topic one way in the sleep lab and another way in the ICU.
Well, and I suppose that has to do with risk benefit and that patient population.
Absolutely, 100%. But what it also brings up is that as a society, one of the big take-home messages from this entire experience needs to be that we cannot get ourselves to a position with a single vendor and a single device. We need to have a little bit of variation, because not only is it good for the marketplace, but it's a safety and a security issue that we can't get around if you have a single manufacturer with such a high percentage of the market.
Well, and it's so funny to me, right? When we were kids, we learned, don't put all your eggs in one basket. And yet all of a sudden we're kind of between two baskets. And for some populations, there really is only one basket.
Yeah, that's absolutely true. And I think part of it is that we're looking at a specialty device and a niche area. We're also looking at something that's relatively new. Remember that a home-based non-invasive ventilation with what we would call a BiPAP machine didn't really become a realistic option until about 95. I mean, there were people in the polio days at home with, huge mechanical ventilators and iron lungs, but that's not what we're talking about today.
Right.
And so because it was such a niche product, it was always going to be difficult to induce other manufacturers to try and get into the market. And I do think that's one thing that as AASM moves forward, we need to use our voice and our power to make an understanding in the marketplace and within the country that we need to support some diversity so that we don't get into this situation, even if we have a relatively small market.
Well, and your point is so well taken, right? With the Omni Labs being recalled, it's really hard to find a ResMed titration device. I mean, we're always told, oh, next quarter, by the summer, by the end of this quarter, right? And we're still struggling. Are there other companies that even make in-lab titration devices?
Yeah, preparing for this interview, I really struggled to find any legitimate options. It was super tough. I couldn't find anything.
No.
That doesn't mean they're not out there, but I couldn't find it.
I haven't been able to find one either, if that makes you feel any better.
Yes, that does, actually.
However many years, right?
Yeah.
Because it is challenging. We talked about this consent, and, you raise a really interesting point about having one institution and having two different policies. So one for the ICU and then one for the sleep lab. And is having patients sign a consent the right thing to do, sort of in the spirit of transparency? Or are we taking, what is our other option?
Yeah, I think that the best thing that we can do for patients is, rather than having them sign a consent the way you would for, say, a procedure, I do think that it is best up front to say, we are giving you the best treatment we have available. And just leave it at that, because by the time you're in an ICU and you need ventilatory support, there's not a lot of options. But the problem is, this is now in the public sphere.
Right.
I had a patient the other day say to me, oh, I follow on ProPublica. I know what's going on. Okay, so if I don't bring it up, then I look as if I'm hiding something.
Right. And that's my concern.
And we never want to be seen as either being unaware, uninterested, or worse, untruthful. And so I think that it's worth it to say, hey, we're aware that this isn't perfect, but we're offering you the best therapy that's currently available.
Yeah, and I think, sometimes, at least for us in clinic, we have a discussion about sort of one night of exposure versus longitudinal, month and year exposure.
For sure.
Right. And so, yeah, it's been challenging because you're right. You don't want to be seen as hiding it or sort of being in cahoots with industry, right?
Exactly.
I think we've had in our field, I think we've kind of struggled with, patients sort of assuming that we are making a ton of money off of them by writing prescriptions for CPAP, and we get all these kickbacks. And, I don't know where this comes from, but it's still
right?
there. It's still there. Like even just a few months ago, somebody was convinced I was getting kickbacks from referring physicians and from CPAP companies. And I'm like, I promise you I am not.
Yeah.
So
yes.
it's
yeah,
hard.
I definitely hear that. Although that is the one advantage of having so much time in muscular dystrophy and ALS clinics.
Oh, yeah, I suppose, right? Because it is sort of a much different conversation, the risk-benefit conversation.
Absolutely.
So,
Absolutely.
do you guys have then a lot of these recalled inpatient devices at your facility?
Yeah, so that's a very important question. We do. The numbers become staggering when you do the math. So at any given time, we're running between 80 and 100 of these recalled devices every day.
Wow.
And we're just one hospital. So when you think about a hospital system that may own 10 hospitals, now you're looking at 10x. If you're looking at a state like the state of Illinois that has, 5 or 8 or even 10 large hospital systems, the numbers get exponential very quickly. So the biggest problem isn't just that we don't have replacement, but even if we get a replacement, manufacturing enough devices fast enough to meet the need is staggering.
And I suppose they don't have, the market is that you buy X number of devices. It's not recurring sales. And, so that enticement, I suppose, is not there.
Well, yeah, I think that the bigger problem with that is going to be literally having enough of the components in order to make the devices. That I think is going to be the much bigger limiting factor. Issues with availability of parts like silicone, but also the microprocessors and the chips. These are going to be really limited, resources. And even if you had enough factory space, if you don't have the basic building blocks, you're not going to be able to produce what's necessary when the volume of devices is as high as we're thinking.
See, and it's funny to hear you say that because I kind of felt like that was a bigger issue early COVID and that had sort of gotten a little bit better, but I guess not.
So it's definitely gotten better for the things that we could predict, like the use of regular CPAP, right? We're not sitting here having to worry, is it going to take me 3 months to get a CPAP machine? So I think the regularly occurring stuff, yeah, we're okay. I think where we're getting into trouble is with the unexpected and the unpredictable. That's the model where we don't have enough options within the system to meet those unpredicted needs.
Yeah, that's very fair because so many of the things that you have been thinking about, I have to tell you, it never really even occurred to me. Like your concern about auto track and translating, right? Because my population is very different than your patient population.
Yeah. So not only is that an issue, but I think one of the things that this is highlighting is the siloed nature of sleep medicine. And, you and I have talked about the fact that this whole thing, we need to sort of put the silver lining to it. And if there is a silver lining here, one of them is that it's made us aware of the fact that sleep can no longer be a silo unto itself. We need to be a part of the bigger medical communities in which we live so that we can have joint answers to complicated patients and complicated questions. And so, like we were talking about before, having inpatient sleep services, interacting with complex neurological programs and pulmonary programs, ENT programs, and anesthesia programs. And if what comes out of this crisis is that we aren't siloed and we're now integrated, then you know what? It wasn't all bad.
Well, and it's so funny, right? It's perspective. Because I think we were chatting about how when SERVE-HF came out, that was the biggest deal in that moment. I remember being at the sleep meeting in one of those gigantic halls, and Dr. Morgenthaler was talking about it. And every seat was taken and standing room only, right?
Yeah.
But now looking back, then we had COVID, then we had the Philips recall, and then another, iteration of the recall, and on and on and on and on. Now the SERVE-HF stuff, I mean, that was a piece of cake compared to this.
Yeah. I wish that I had a time machine and I could go back and tell my prior self, don't sweat it. It's the small stuff.
I wonder if that would have been scarier to hear, though, that there's something even bigger.
True. Yeah, because then you'd be like, oh no, what's coming up next?
So you taught me something that made me kind of reflect upon our profession about how the risk, right, that we have to kind of accept this risk.
Yes. Yeah. And I do think that that's another thing that we are learning as sleep doctors to expand our worldview, because we had, I think, gotten onto a treadmill in which our worldview of how we viewed the way we delivered care and the patients that we were serving was kind of limited and remote and repetitive. Mm-hmm. And one of the things that I think actually is a good thing about everything we're going through is that it's forcing us to learn different models of care, to learn different modes within the ventilatory devices that we have so that we can provide care in ways we never have before. And I do think we're all better off for that.
And you did very specifically tell me and teach me that if what we were doing wasn't important, we wouldn't be having all these risks.
Yeah, that's true. So we were talking about like when the SERVE-HF study came out, it was right on top of the ALS diaphragm pacer study that also had a DSMB, a data safety monitoring board, that came in and shut the whole thing down. And I was at the time very upset that I had 2 studies shut down within a month. And my division chief came up to me and he said, Lisa, this only happened because what you do is challenging, what you do is worth it, and the patients that you're taking care of are within the most challenging set. And so I do feel like we need to learn that lesson, that if everything went perfect for us, what we were doing wasn't worth it in the first place, that when we have these stumbling blocks and these challenges, it's because we're stepping up our game to meet the bigger need, and we're all better off for it.
I love those little nuggets of wisdom that stay with us forever. And it sounds like, I'm glad you're sharing that with us, because it does feel a little bit like, we've had one thing on top of another on top of another. So you're right. What we do is important. It is meaningful.
Yes, it matters. And that's why it's tough. It's tough because it's worth it, and it's tough because it matters.
Well, so any final thoughts for us?
I just want people to continue to take up the challenge, not get discouraged. And I also think that, and you and I talked about this a little bit, the next challenge with this is going to be challenges between our insurance providers and our DME companies in limiting access to actually getting the equipment. And so I have a feeling the next time you and I talk, that'll be the topic of conversation.
Well, because you mentioned something, right? That we kind of talked about how we're kind of being pushed towards this HSAT auto PAP model, and that definitely isn't going to work for your patient population.
Right. It absolutely is not. And on top of that, we now have sort of AI software making decisions about who gets what device rather than the sort of good direction of national coverage and local coverage determinations. Hey, listen, we weren't necessarily happy with those, but at least we knew what they were and we knew how to operate within the system. The problem that we have now is it's the Wild West of the coverage determinations could change any day of the week. And so how do you care for a patient in a system where you cannot predict what's going to happen tomorrow? And I hear the frustration out there from every corner. Why am I being denied a bi-level? Why am I being denied EO466, which is a home mechanical ventilator? And without being able to really have a good understanding behind that, we're not going to be able to deliver care. And so we have worked really hard on trying to make this a more regimented system, but it's been a problem. And I have to say the ASM has been very supportive in our work to get this done.
Yeah, it's really kind of incredible how much stuff goes on behind the scenes. You know, how many like months and years of work, and then you'll get like a little blurb on an email saying, "Oh, by the way, this payer policy was fixed."
Exactly. It's like an email that has 4 lines on it, but it represents 10 years of somebody's work. Yeah, that's
we
so
probably,
true.
Well, we probably do need to hear a little bit more about some of the wins that the ASM actually does have, right?
Yeah. Absolutely.
Yeah. So I will put in another plug for your Choosing Sleep video. I thought it was terrific. I mean, I paused it. I had to rewind it. I was like, oh yeah, I forgot about that because I, haven't thought about it in so many years. So it was great. I learned a lot, and I appreciate you coming on to share your considerable expertise with us.
Well, thank you for inviting me, and I'd hang out with you anytime. So.
Thanks for listening to Talking Sleep, brought to you by the American Academy of Sleep Medicine. For more podcast episodes, please visit our website at aasm.org. You can also subscribe through your favorite podcast service. And if you enjoyed this episode, please take a moment to leave a rating or review. For more feedback or suggestions, email us at podcast@aasm.org. I hope you'll join us again for more Talking Sleep. Until next time, this is Seema Khosla, encouraging you to sleep well so you can live well.